Move on to the vendor panel. I'd like to call the vendors up to the panel, please. And we'll start, the first talk will be by John DeLong. He's the Vice President of Clinical Content and Product Management at Medicalis. He brings 15 years of experience from the medical software industry with focus on technology strategy and product marketing in competitive technology environments.
First of all, I'd like to thank the ACR for the opportunity to spend a few minutes with folks here. Thank you to Callie and Gary. So from a clinical decision support perspective, I just have 3 or 4 slides from a vendor's perspective on how does somebody like Medicalis think about decision support. So from Medicalis' perspective, what is imaging content? We certainly think about imaging content as evidence-based guidelines. Certainly, that's a good thing from an evidentiary perspective. We think about those evidence-based guidelines being assimilated by national medical societies like the ACR. We are extremely pleased that the ACR has decided to undertake this, I think, broad and long-term initiative to create guidelines that can be used across the spectrum of clinical practice. So clearly, that's a good thing. There's also, there was a question around national guidelines, local guidelines. Certainly, as we have rolled out to customers, we have seen the need for localization, whether that's at the specialist level or from a local clinical best practice. As they engage physicians from a clinical perspective to get their buy-in to the process of decision support, and over time, we then see the local guidelines coming together with the national guidelines. It really is a mechanism to capture physicians' attention around decision support and bring them into the fold of decision support is a good thing. It drives value in the organization. So clearly, that's a good thing. And then content can actually be delivered in really 2 forms. One as reference documents. We all know those today. There's all kinds of websites where you can go to, read a document, download a document, or as executable knowledge. The fundamental difference is a reference document isn't necessarily wrong or incomplete. It is incredibly ambiguous. Folks talk about the things that are either easy to talk about or have the highest level of prevalence in the market today. When you actually start taking documents and creating executable knowledge, and I'm sure that the team from the ACR certainly understands this, is when you move from documents to executable knowledge, you now need to fill in all those gaps. So we talk about female patients with a headache and a history of brain tumor. Well, what about if the patient's male? What if the patient's a teenager? You have to think about all those different clinical scenarios. So we certainly think reference documents bad from a decision support perspective, and executable knowledge is very good. And really, that's fundamentally why Medicalis is squarely behind the ACR's initiative of creating clinical content that can be accessed through web services. Is content enough? And that's really from a vendor's perspective what we need to think about. Certainly we think clinical decision support is much less about a technology problem that customers have to solve. And as Callie indicated, it's much more about the clinical transformation that decision support drives within an organization. And so clinical transformation is about engaging physicians with the context that they deliver healthcare to their patients. A neurosurgeon talks to patients, engages patients, and thinks about clinical conditions at a very different level of clinical granularity than does a family practitioner. And so a common set of guidelines, you have to actually approach the delivery of those guidelines to the context of the physician constituency. And I think that's really done through technology in terms of enabling guidelines, disabling guidelines, depending on the constituency that you're delivering them to. And in some cases, we've actually seen just the static presentation of guidelines certainly drive the increase in appropriate use of imaging, but we were actually involved in a study in Canada where it actually increased the cost. And what I mean by that is we saw physicians accepting recommendations where they felt like, I was ordering ultrasound, but decision support suggested CT, so clearly that's a better way for me to go. On the other hand, I'm ordering CT, and decision support and the guidelines suggested ultrasound or no imaging. That feels like, I'm not moving in the right direction, so I'm going to stay with what I had. And so that's just some of our experience with one study. So moving on beyond content, and from Medicalis' perspective, we really think content is the cornerstone of an imaging management program. And as we see a couple of things happening in the industry, one, as payment models are actually changing from fee-for-service in radiology to bundled payment, ACOs, the revenue generation of radiology begins to shift to helping an organization manage the cost associated with radiology. And also we see in the industry the risk of payment shifting from health plans to hospitals, and radiology groups need to participate in that in some manner. And so as we actually see the management of the costs associated with radiology currently now squarely inside of the health plan, both private health plans and public payers like CMS, I think that's why the CMS MID program is on at the moment, is they have selected RBMs to manage that cost line. And RBMs are not just using content. They use content, they use technology, they use process, and they use other diversionary tactics to manage the costs associated with radiology. And so what a vendor like Medicalis thinks about is how can we actually leverage the cornerstone of content to allow hospitals, radiology groups, and radiologists to actually build, participate, and deliver in delivering an imaging management program to the institutions that they're serving as a value-added service to help that organization manage the costs associated with imaging. So really the components I just talked about, content, clearly evidence-based guidelines, technology, so content is provided by content providers, just like the ACR Select. Technology, plug and play with enterprise EMRs, ability to map, translate inbound procedures and indications from enterprise EMRs, reporting and advanced analytics, who's ordering what, why did they order it, was there content coverage, was advice and recommendations given, did physicians accept that advice, and so forth. And I think one of the things that I have learned over the last 5 or 6 years in delivering decision support is actually meeting the physician at the context where they're interacting with the patient. So I am a neurosurgeon interacting with a female patient post-operatively, and when I go to order a test, I do not want some generic imaging guideline to pop up. That is not a good use of my time. I want a contextualized, helpful piece of content, if there is any content to come up when I'm actually ordering tests. And so the technology platform needs to be able to be deliver context-sensitive intelligence based on age, gender, physician specialty, location, and potentially the health coverage of that patient. And then clinical engagement, technology, clearly from technology providers, that's where Medicalis thinks it plays in the equation. Clinical engagement, I think Gary, Dr. Wendt talked about this in terms of it has to be top-down. You need to engage physicians and other staff to prepare them for why is the organization doing decision support, and that really is the end user team or the customer that's responsible for that, and policy establishment. So when we're delivering guidelines, so why are we doing that as an organization? What happens if we deliver a recommendation and physicians don't accept recommendations? Is that okay? Is it not okay? Is it okay for them to not accept recommendations based on weak evidence, but where the evidence is strong? Do we actually want to turn up the policy in terms of requiring a consultation with a local radiologist before that test occurs? Certainly Medicalis believes as the fee-for-service moves into bundled payments, ACO type model, that having those enforceable no stop to soft stop to harder stop, configurable in an organization, is going to be something that's absolutely required. And that policy establishment is squarely, needs to be the end user or the customer that actually establishes that based on their health plan contracts and based on how they want to engage their physicians from a top-down perspective. So I just want to, there's really all pieces to the puzzle. Thank you to the ACR for really stepping up to the plate to provide what I would consider to be one of the cornerstone pieces to the puzzle, and that is the content. And certainly we think there is a long relationship between a vendor like Medicalis and the ACR.
Thank you, John. I'd like to introduce Dr. Kang Wang. He is he's been in the medical industry for a while now. He's a pioneer in web-based multi-institutional electronic health records. He was a CTO of Amicus PACS from 2000 to 2010, and he's currently in a new role with Health Fortis as a CEO. So I'd like to welcome him.
Thank you very much. And so I worked for 10 years for a past company, and before I started Health Fortis. So looking back, it's very interesting that I think some of the people in the audience will relate with me. When we sign a big contract, we say, hey, this institution makes 1 million studies a year, we all celebrate, okay? So it's a great news for us in the 2000 to 2010 period when I was with the PACS company. But the fact that 300,000 of this 1 million is unnecessary or inappropriate, we never talk about it, okay? And in a fee-for-service world, not many people talk about it. Payers try different ways, RBMs and all that to control it. And I think Health Fortis and the vendors here in this new world of ACO and the risk sharing, we need to find a more efficient ways for physicians who now have incentive to control the unnecessary utilization to get the decision support they need at the point of their decision, okay? So that's why I started Health Fortis and why our tagline is decision support at the point of decision. So in this next 10 minutes or 15 minutes, what I want to share with you is like a case study that we did. And we developed this system for 1.5 years, and then we deployed it since January of this year. So this presentation is about this deployment, the lesson we learned, and some statistics that showed that a good system at the point of decision really can make a difference. Okay, so we started the designing of the system working not with a radiologist, but with the ordering physicians. So this is a system that from the day one is designed with ordering physicians. So I remember when I started this process 2 years ago, the first thing my customer and development partner told me is, you're really not competing with any of the vendors out there, okay? The real thing that you're competing with is that order path that most of my physicians are using to order radiology, okay? They are so fast, so mobile, and so convenient, it's very, very hard to take that away from them, okay? A lot of EHR vendors tried with their order entry module. CPOE has been there for 25 years, and not very many of them have good reputations. So speed is the first priority. And we introduced a lot of technologies to speed up the ordering of the right exams. A lot of the talks you have heard and probably the system you have seen is mostly make a judgment after the physician has ordered something, right? I want to order a CT because I have an abdominal pain patient, then you get a score of 4. And then you have to change to something else. And what we said is a real decision support should guide the physicians towards the right order, okay? Not make a judgment after they already placed the order. So we started with this new methodology of having a Google-like search mechanism where as soon as you know about the patient or the symptom diagnosis you want to do, the system start to give you recommendations, and it's very easy for you to just to select from the top recommendations and be done with your order. Now, at the beginning, 2 years ago, people would tell me, yeah, it's not the habit of the physicians, okay? They tend to come in knowing they want that CT abdomen without contrast. Then you try to change their opinions. That's what your role should be. And, but since we went live in January, in the last 8 months, I can report to this group 75 plus, close to 80% of our orders entered into our system is actually selected from our recommendation instead of they type in anything, okay? So we made the decision to go with the best procedure, the easiest one. So instead of typing, you just click. And that has made a great impact. And with our system, we do 2 things to be better than the order pad, okay? We first try to be as fast as the order pad. Then we provide decision support, very non-intrusive. There's a huge discussion also about soft stop, hard stop, no stop at all, and whether there's an impact. And our experience is if you gave the physician the right suggestion at the right moment and make them to go with the best procedure be the easiest way, they always go the easiest way. If the easiest way is always also is the best way, then that's the best of the world. So there's no really need for any hard stop and anything like that. And so we also do things like duplication detection. You might have a CT abdomen perfectly fine for this particular patient, and because you have kidney stone as a suspected diagnosis, but someone else might have done a CT abdomen for this patient 2 weeks ago, right? It's stored in your PACS, report is available. So at that moment, when you put in the order, it's the perfect time to give them the warning about duplication. So we integrate with companies like Live Image, like any other PACS system to do that duplication detection. So that's a huge value add at the point of care. And also, people asked whether ACR's rule is comprehensive, and it covers all the scenarios. The answer is no. Okay, so in our last 2 years developing these systems, ACR represent probably 55% of our clinical scenarios in our search engine, and our customers, their clinical committees has add another 40% So our system do allow you to do this, and we also have an integrated reporting component that tells you exactly in real time how your ordering patterns are in your ordering communities. And this system is integrated with EHR, so the physicians who do use EHRs for charting can directly access the system in the patient context with single sign-on and with problem sharing. So if you already putting a headache in your EHR as your problem, and we know it, and we'll use it to drive our search engine to find the appropriate guidelines for you. And we can also submit our result back in real time into the EHR systems. We offer it as a cloud deployment model, so we don't sell, we only have 1 copy of the software that runs on our data center. So that makes it easier to upgrade the content with ACR Select, for example, in real time and benefit all of our customers. And our system is also refreshed very, very frequently. So here is, next 2 slides are some statistics we have, okay? So you can see from February to July of this year, 6-month statistics. Our user base has really increased in terms of their appropriateness scores. So the green bars represent the procedures that is according to ACR and our customers' own rules is appropriate. So you can see it's increased from 60-some% over 80%. And here's also an impact. So when we hear the studies that 30% or 50% of studies are inappropriate or unnecessary, and this is the first time, at least in my professional experience, that I have seen it with my own tool, with my own reporting statistics. So we measured 25 weeks since we went live, and with the same 25 weeks of the same group of physicians, and in terms of the number of MRIs they ordered, okay? Now, we normalized it per 1,000 patient visits. So if they are less busy or more busy this year than the last year, we factor that out. And so you can see that in this 25 weeks after they deployed CDS, we have seen close to 25% decrease. 25% decrease, not the slowdown of the growth, but 25% of decrease of their MRI orders. Now, the next question we ask ourselves is that decrease overall, right? Does people use CDS or not use CDS have seen the same decreases? So because we only deployed clinical decision support in a subset of the physician groups, we have the luxury to do a difference of difference comparison. So we took the same time period, the rest of the physicians, and what they have ordered for their physicians, and we actually see a slight increase in their comparison. So we're very comfortable to claim that we using CDS, which I think is consistent with the previous presenters, really reduce the utilization in a good way. At the same time, you can see the previous slide shows the appropriateness score actually all goes up, okay? So those are, I think, without hard stop or even soft stop, it's with a new methodology that really gave decision support to the physicians at the point that they need it. And there's a bunch of slices and it's the UIs. If any one of you want a demo, I can easily show you and happy to show you at my desktop. So this is a reporting module. We actually know, our customer know in real time which region or which, even you can go to the physician level, how many of them have contributed to inappropriate exams. Right? We have run a very interesting report. We said, what is the top inappropriate exams that those physicians are ordering? Okay? We have a contest of people guessing, and radiologists guess, and our physicians guess. Most of them guess it wrong. Actually, the answer is X-ray spine. Okay? That is not the CT or MRs. The X-ray spine is the mostly ordered inappropriately. And we also know for what reason they're ordering this. For uncomplicated back pains, they're ordering a lot of back X-ray spines. So those are actionable informations that you can only get when you have a decision support system at a point of care when every orders flow through the system. So the three factors for inappropriate, we did surveys of our doctors and we asked them why you're ordering less and all that. And they said, I order previously, sometimes, not very often, but sometimes because of, I just don't know, right? So, but a lot of times because I'm practicing defensive medicine. I know I should not order it, it won't yield anything, but to cover my X, I need to order this. And this tool actually gave them, this is what they told us, gave them a support to defend themselves in case something happened. So with that, I want to end my presentation. Thank you for reminding me. Thank you very much.
Thank you. Thank you, Kang. Our last speaker is Dr. Steve Herman. He is a radiologist, practicing thoracic radiologist at the University Health Network in Toronto. He is the founder and president of MedCurrent Corporation.
Thank you all for the opportunity to share our system with you. We've had the opportunity over the past few years to talk to many hundreds of users at many hundreds of hospitals across the country about the ACR appropriateness criteria and about decision support in general, and we wanted to share what we've heard with you and then show you what we've done about that. So the main problem, of course, that one is trying to solve is the inappropriate utilization of medical imaging tests. And of course, the ACR appropriateness criteria are a great first answer. But despite the fact that they're the best data set in the world, they've been the product of many thousands of hours of doctor time, there has been very little utilization of them out there in the real world. And then we set out to find out, why is that? And in general, the ACR, the appropriateness criteria, are just not easy to use. And why is that? One, they're just not easily accessible. They're not efficient to use. And they're not necessarily suitable in the specific practice where they need to be used. So let's just talk briefly about each of these. People have covered this, but when one is about to place an order, they're inside their EMR. If they need to get to the ACR criteria, they have to go to a different browser, do their thing there, find out what the best test to order is, and then come back and actually place the order. In terms of efficiency, there's many steps. Even when you're at the ACR website, there's many steps to go through. You have to search for what the patient problem is. Many different topics can come back. You read through the list, you find the topic that you want. There might be variants within that, and then you get presented a list of possible studies that that you can select from that may or may not be enough for you. You might have to actually go into the text information and read it. So this is just far too cumbersome for busy referring physicians. And of course, you hear that time and time again. As well, they're not necessarily suitable. Now, you might not be able to read this actually, but in this particular variant, CT abdo-pelvis has a score of 9, and MRI of the abdomen and pelvis has a score of 9. And in the comments section there, it says the decision for which one to use is based on local experience and desires. So let's say you're a hospital that wants to guide, your radiology department that wants to guide your physician to CT, for example. This doesn't work for you. So in general, the ACR appropriateness criteria are not easy to use. And that led us to develop what we call Order Right. Order Right makes the appropriateness criteria easy to use. Now, how does it do that? By being simple, intelligent, and empowering. Now, simple and intelligent might sound they're contradictory, but they're actually complementary to each other. So let's start with those. We start with I was told to demo some of this stuff. We can't do a live demo in this, but we'll show some screenshots. So in terms of the simplicity and intelligence, we start with a very simple, clean interface, just one text box where they enter in information. But under that is a very complex data structure and sophisticated algorithms that are driving what the UI is showing. Secondly, the workflow. You hear time and time again that clinicians are very, very frustrated dealing with decision support in general because it just doesn't suit their workflow. So the design of this workflow was also to make it as simple as possible, only put up the very specific questions that need to be asked in order to get to the answer to the results page as quickly as possible, and then make that results page as simple as possible as well. Now, we've integrated Order Right into Cerner's EMR, which I'm going to show you. And another important feature of the workflow is to not frustrate the physician and ask them questions that they've already answered elsewhere in the EMR. So there needs to be free exchange of data between the two systems. So let's just show a typical order. We're looking at a screen from Cerner's CPOE where the doctor is selecting the procedure, which in this case is a CT head. By the way, they can leave it blank and just say, I don't know what to do, you tell me. But they've ordered a CT head here. Order Right gets called up. They, in a Google-like search fashion, they type in what's wrong. I'm sorry, it's hard to read, but they've typed in a few letters, and they'll select the patient has a headache. It then asks, tell me a little bit more about the headache, and again, in a simple fashion, this patient has a chronic headache with some new features. Back comes the decision support result. And you can see that the score for what they ordered, the CT, is 5. It finds that there's a higher score, so it puts up a recommendation. MRI has a score of 8. With one click, the doctor picks the MRI, goes next, and they're back into Cerner, and that CT has been changed to an MRI, And the fact that the patient has a chronic headache with some new features is now back part of the patient record. So everything that was collected inside OrderWrite is now shared, and there's no canceling of orders or anything like that. Simple. I thought I wanted a CT, one click, switch to an MRI. Let me just show you one other example. We took the ACR data from the PDF format and spent many hundreds of hours working with subspecialty radiologists, structuring the knowledge in such a way that the workflow is never more than 2 steps. The ordering doctor will know that it's only going to take them 2 steps, sometimes 1, as it was just the first example, to get to the results page. Because what we didn't want to do is ask a question, depending on the answer, ask another question, depending on the answer, ask yet another question, and so on and so on. The doctor's going to say, when's this going to end? So they can be assured that it's 2 steps maximum. So we'll show another example. I'll stick with headache. This time it's a new headache. Now there's the second step. It's asking, I need to know a little bit more about the patient. We'll say they're immune compromised. Back comes the result page. I'll just show you a few other things that are here. I'm sure I'm doing something wrong, but the pointer doesn't seem to be working. But there's a little section there where you can see text. This text is specific on a procedure-by-procedure basis, explaining why that score is what it is, because we think that clinicians are much more likely to accept a recommendation from a computer if he or she understands why that recommendation is what it is. So there's procedure-specific notes that explain why, for example, CT is a 5 and MRI is an 8. Inside those notes, there might be references listed. As you can see here, there's sometimes URLs where they can click on and go out and see even more information. Beside that appropriateness score is a priority score. So that's a sense of urgency, how urgently this test should be done, where, for example, 1 is stat. People are more and more concerned these days about the radiation they're exposing their patients to. So the last column is showing the radiation level that test will expose their patient to. That, of course, comes from the ACR. So again, they've selected MRI. It's back into Cerner, and the clinical information is passed back as well. Now, the third feature that we heard about, virtually every single hospital we've talked to, not 100%, but for sure 90%, told us that the ACR criteria are great, but they want to tweak them for their own specific needs. We saw an example before where the MRI and the CT of the abdominal pelvis, they were both 9. They wanted to be able to direct their doctors to pick one, for example. We talked to a hospital in Baltimore that said patients in the ER, for certain indications, they want them to have an MRI, but only during the day, because at night it's more difficult for them to get an MRI. So in that case, they want to direct the ordering docs to a CT scan because they have one in the ER. So you need some flexibility. And so this is what led us to develop what we call the Rules Authoring Studio. This allows authorized users to tweak virtually every component of the rules that are driving what the ordering doctor sees. I'm just going to touch the tip of the iceberg here. There's a rule that's driving the example that we just used, and it's difficult to see, but there's the result page associated with that rule. And what we can, oh, there it is. There's the score. That was a 5 for CT scan. The other parameters are there. By the way, you can auto protocol. We've left that out here. This is an ACR rule, so it's checked. And there's the descriptive information that explained why that score is what it is. We made a change to that, and we made that 5 into a 9. Now it's not ACR anymore, so it's a custom rule, and we've added some new explanatory text. We can immediately after that go and run that exact same order that we just ran, and let's just do that. Of course, it's slides, but this is what happens. We order that CT, patient has a new headache, they're immune compromised, and now comes back the result that we just changed. And if the score now comes back as a 9. It's not an ACR rule anymore, it's a custom rule, and our new explanatory text is there. So again, very important to be able to customize the system to work the way you want. Doctors want to feel empowered to have the system work the way that they want. They don't want to be told what to do. Okay, medicine is practiced locally, and what may be done at one hospital in one hospital might be different than a hospital on the other side of the country or across the street. So again, OrderWrite makes the appropriateness criteria easy to use. One last feature is analytics. Again, I'm just going to touch on this quickly, but the system captures every mouse stroke, every bit of data that's been entered into any field, and it's there to be mined. One quick example, here's some overall orders that have gone through over a certain period of time. The green is the high score, 7, 8, 9, yellow, the medium, 4, 5, and 6. We can drill down into that and look, for example, at the specific clinics that are sending in the patients and see how each clinic is doing. We can target one specific clinic, delve down into that, and look at the specific doctors at that particular clinic. And we can see that there's an outlier, this one that's all bad scores. We can delve down into that specific ordering doctor and look at his or her specific orders. And this isn't showing up very well, but we can see that what the doctor requested was I think it's an ultrasound of the elbow. It has a score of 6, I think. The system came back and recommended an MRI with a score of 9, but the doctor still selected the ultrasound with a 6. And we see the clinical indication is listed there, and so we know all the parameters of the order. So in summary then, OrderRight is simple, it's intelligent, and it's empowering. And thereby, OrderRight makes the appropriateness criteria easy to use. Thank you.
So we just have time for a few questions. Yes, one over there. David?
There you go. It's fantastic. Ever thought about putting up there? I love how you have not just the score, but also the priority in the radiation. What about cost?
Well, people have asked for that, and that's a planned. People have asked specific costs or just another factor to guide, like a utilization type of resources, a score as well. So
yeah, I wouldn't necessarily need a dollar amount, but like, kind of like restaurants, $1 sign, $2 signs, $3 signs, something like that. But seriously, many doctors, they have no clue. The fact that they've just ordered something that's 10 times more expensive, without thinking about it all.
Is there a dollar? Is there a dollar menu?
No, that's a good question, and that has been asked for repeatedly. Because as you said, doctors have no idea, and just seeing that can make them choose possibly the more resource-efficient tool to order.
Right, and I don't think that's bad.
Actually, I got some pushback on that. We thought about that, and because the systems are used mostly in the exam room, and people said, don't display the dollar sign because otherwise you will piss off the patient.
Yes, question.
Information from the medical record, contrast to allergies, contraindications to MRI, clinical information, parsing text. Where do you stand on that?
Well, there's access to the clinical database inside the EMR, which specific fields can be queried to answer those questions, including the date of the last exam, as was mentioned, a very important thing. So you can warn them, hey, the patient just had this yesterday, that type of thing.
I would just add one thing to that. It is Journeyman's work today to actually get access to that data. It tends to be an integration project. I think one of the things that Meaningful Use is driving is that the encapsulation of patient data in the EMR or EHR is now going to be exposable using CCD documentation, that an external system then can query, parse that as they need it, when they need it. So I think that's, from Medical's perspective, one of the things that we're very much looking forward to. But today, that's all attributes that then need to be sent into our web service in order to get rendered.
Okay, thank you to the panelists, and we'll go to our last speaker. Thank you very much.